All right, welcome. Thank you again for being with us this morning. My name is Katie Junk, and I'm with Ochsner Health, and I'll be your moderator for today's webinar. Just a couple of housekeeping items before we get started. We will have a Q&A at the end of the presentation, so please feel free to put your questions into the chat or the Q&A at any time, and we will do our best to get to everyone's questions at the end of the presentation. As you all saw, this presentation is being recorded, so we will be sharing the link to the webinar recording after today's webinar. So as everyone is aware, GLP-1 medication therapy is a very hot topic right now, particularly for employers, for health plans, and for members. So today we're going to cover a few things. Dr. Rachel Daughtry is going to give us a clinical perspective on how these drugs work, the clinical value and efficacy, and the population health benefits. And then we'll transition over to Dan Shields, who is the CEO of Digital Medicine, and he will take us through how Ochsner is balancing these challenges as a 30,000 life health plan and as a provider of care, and also how we're managing these things ourselves. So to kick things off, we do have Dr. Rachel Daughtry with us, and I want to share a little bit about her. So Dr. Rachel Daughtry received her medical degree from Louisiana State University School of Medicine in New Orleans, Louisiana. She then completed her internship in internal medicine at Ochsner, followed by a residency in preventative medicine at Tulane University. She also holds a Master's of Public Health degree from Tulane University School of Public Health and Tropical Medicine, and she is both certified in preventative medicine and obesity medicine. She's been on staff at Ochsner Medical Center since April of 2019, and she is currently practicing obesity medicine with the Comprehensive Weight Loss Program at Ochsner Medical Center. So, Dr. Daughtry, I will give it over to you now.
Thank you, Katie. Welcome, everyone. I appreciate you taking the time to join us this morning. So like Katie said, today I'm going to start off by talking about GLP-1 and GLP-1 agonists. So what is GLP? The development of these medications. I'll go into the STEP trials, which were a series of trials that led to the approval of semaglutide for the treatment of obesity. And then I'm going to go into talking more about obesity as a disease and hopefully really drive home the point of why these medications are so important to us and to our patients. Okay, so first, what is GLP? So GLP stands for glucagon-like peptide. It's called an incretin hormone, meaning that it stimulates insulin release in our bodies when insulin is needed to metabolize sugars and carbohydrates. So it's secreted by cells in the small intestines in response to consuming a meal. Receptors for GLP are found throughout the body. And you can see here, I'm not going to go through all of these, but you know, they're affecting a lot of different organ systems. Now, naturally in our body, GLP is degraded very quickly. And so there have been developments to make GLP-1 agonists, which will get these effects for more longer term, more sustained term. So looking at this is a timeline for GLP-1 agonist development. Originally, they were approved for the treatment of type 2 diabetes, first coming out in 2005. The original GLP-1 agonists were daily injections. So you would be responsible for giving yourself an injection once a day. Victoza came along in 2010, and that is the drug liraglutide. And then finally, in December of 2014, liraglutide was approved for the treatment of obesity. So this was the first GLP-1 agonist to be approved to treat obesity. Again, this is a daily injection. And I do want to point out, most of these medicines are, when they get approved for the treatment of diabetes, they're branded with one name. And then when they go on to get approved for the treatment of obesity, they get rebranded as a different name. So you'll see a repeat of a lot of these drugs. And this, you know, is important. It does cause quite a bit of confusion for patients. So It's something that's important to point out. And then if we look a little further, a couple years down the line, in 2016, Ozempic was approved for the treatment of diabetes. Now, Ozempic, as we all know, is a once a week injection, and it kind of tends to be the umbrella term that everyone thinks of for the injectables. And so again, pointing out that Ozempic is also the same drug that's in Wegovy, semaglutide, which got approved in 2021. So Wegovy was the first once a week injectable to get approved for weight loss. Now we have a couple of new kids on the block that were approved for both diabetes and weight loss. You have Mounjaro and Zepbound. Those are the latest ones to come out, both of those being the drug tirzepatide. I'm going to focus mostly on semaglutide, specifically Wegovy for the treatment of obesity. So I'm going to go through, let's see. Okay, so I'm going to go through the STEP trials, standing for semaglutide treatment effect in people with obesity. So these were the trials that led to the approval of semaglutide for weight loss management. STEP 1 was published in the New England Journal of Medicine in March of 2021. The population of participants included patients with obesity, so BMI of 30 or above, as well as participants who were overweight with a weight-related comorbidity except for type 2 diabetes. This followed patients over a 68-week time period. And as you can see, patients that were in the semaglutide treatment group lost about 15% of their body weight compared to about 2.5% in the placebo group. Now, this trial did include some lifestyle medicine, lifestyle management, in terms of weight, in terms of a low-calorie diet, as well as activity. And patients were encouraged to log these activities, and they did have some individual counseling sessions to go over these lifestyle changes. So on to STEP 2, which was published in Lancet in March of 2021. This one looked at patients with obesity or overweight, but also with type 2 diabetes. So this study compared the 1 milligram dose of semaglutide, which at the time was the standard treatment dose for diabetes, to the higher 2.4 milligram dose. Not surprisingly, the 2.4 milligram dose resulted in a larger amount of weight loss compared to both the 1 milligram dose and the placebo. Okay, and then on to STEP 3. STEP 3 was similar to STEP 1 in that it excluded patients with type 2 diabetes, but this trial added a more intensive behavioral therapy session. So there were about 30 sessions included in the trial with a registered dietitian. For the first 8 weeks, patients were placed on a very low-calorie diet of about 1,000 to 1,200 calories a day, with meal replacement shakes, protein bars, and portion-controlled meals. And then that was for the first 8 weeks, and then they went on to 1,200 to 1,800 calories a day. They were also prescribed 100 minutes of physical activity, and increasing by 25 minutes to reach up to 200 minutes per week. So this one, had a greater focus on the lifestyle changes in addition to the semaglutide. And again, patients lost 16% of the average body weight, those on semaglutide versus the 5.7% with the placebo. Okay, and on to STEP 4. So this trial looked at what happens when you stop taking semaglutide. So all participants had semaglutide for the first 20 weeks, and then they were randomized into groups of semaglutide versus placebo. And so in the first 20 weeks, there was about 10.5% weight loss for everyone. Those that were then randomized into the semaglutide group went on to lose 7.9% of their body weight for a total of 17.4% versus the 6.9% regain in the patients in the placebo that were then randomized into the placebo group. So this, the trial kind of emphasized the need and that this is a chronic medication that, does need to be continued. Step 5 did go on to look at more long-term treatment. So other trials were about 68 weeks. This one went to 104 weeks. So for this one, the semaglutide group, they did find there was a plateau in weight loss around week 60. But again, about that 15% average weight reduction compared to about the 2.5 in the placebo group. So from here on out, I've been talking about the primary endpoints, the weight loss endpoint. So let's take a look now at some of the changes seen in these trials in your blood pressure, A1C, and cholesterol. So you can see here, there were decreases in blood pressure, both systolic blood pressure and diastolic blood pressure in both the 68-week trial, as well as the longer step 5, 104-week trial. And you also see changes here in cholesterol, decreases, total cholesterol, but then also increases in HDL, which is important because that's, that's the healthy cholesterol. That's the cholesterol that's taking the fat away from your arteries. And you see a decrease in the LDL, which is the so-called bad cholesterol. So one that's going to lead to deposits in our arteries and cause health problems. And then on to A1C. And so you can see here, I mean, this is not surprising. These, were originally type 2 diabetes medications. So you do see drops in A1C as well. Clinically, I see a lot of people who, both with prediabetes and type 2 diabetes, their A1Cs normalize over time. So it's very impressive numbers in terms of blood glucose control. And then more recently, there have been studies looking at the effect of semaglutide and heart failure with preserved ejection fraction. This study looked at the Kansas City Cardiomyopathy Questionnaire. And that is a questionnaire that really looks at patient function and some of the symptoms that people experience with heart failure, such as shortness of breath and fatigue. It looks at, like I said, physical functioning, how well can you walk a block? Do you have problems bathing or showering? And, this showed the group with semaglutide showed an increase of 16.6 points. So the scoring for this is 0 to 100, higher scores being better functioning, better health status. And then finally, most recently in December of last year, there was a study showing the benefits, the cardioprotective benefits and reduced incidence of death in the semaglutide group versus placebo group in patients with pre-existing heart disease, meaning previous heart attack, stroke, or peripheral arterial disease. Okay, so now I'm going to talk a little bit about my clinical experience with prescribing the GLP-1 agonist. So some contradictions to the GLP-1 agonist. So reasons why I would not prescribe this. So the big contradiction is having a previous diagnosis, either personal or family history of medullary thyroid cancer or multiple endocrine neoplasia 2 or MEN2. These are both rare diseases. So I think I may have come across one patient who had a history of medullary thyroid cancer in their family. And so that, that's nice, and that doesn't restricts very few patients from taking this drug, whereas, some of your older weight loss medications had, cardiac side effects that you would need to avoid them in patients with hypertension and high cholesterol and, arrhythmias that you don't have to worry about with these medications. So what are the clinical effects I see with these GLP-1 agonists? So first, there's delayed gastric emptying. So food is moving at a much slower rate from the stomach into the rest of the digestive tract. So the effect of this is that you are going to feel full after much less food. So whereas, before you may have been able to clean the plate, now, after a couple bites, you are pushing the plate away. You cannot possibly take any more food. This medications also work in the brain to help with appetites and cravings and reducing those. So you have the improved ability to resist foods or say no to food. So, what somebody brings donuts to the office and you don't feel like you have to have that donut, or you don't have to have that piece of cake at a birthday party. It was recently Mardi Gras in New Orleans, and there are king cakes everywhere. And, a lot of patients, would come and tell me, yeah, somebody brought a king cake to the office, but, I didn't have a piece. I didn't feel like I needed to have that piece, even though, it's going to taste good. But, you were able to say no to that. It quiets that food noise, that constant thinking, oh, what am I going to eat next? That a lot of people struggle with, that constant thinking about food. All right, on to some of the common adverse side effects with the GLP-1 agonist. Most of them are gastrointestinal. I would say the absolute most common one I hear is constipation. And that's usually easily relieved with some over-the-counter medication. The nausea and upset stomach that occurs is generally mild, and it's usually when you first start taking the medicine or when you're increasing your dose, but usually, like I said, it's very mild and tolerable. Now, occasionally, patient will overeat, and, that could lead to some more severe nausea or, possibly vomiting on occasion, but usually it's generally tolerated very well as long as you're avoiding, some of those higher fat foods, fried foods, really greasy, heavy foods that can exacerbate some of those symptoms. So now I do want to kind of talk a few moments about the media portrayal of this medication. As you all well know, it is a hot topic right now. It's all over social media. Celebrities are taking it. Even mainstream news outlets are. There's hardly a day goes by that I don't see an article about these medications. And unfortunately, I really believe that the sensationalism of these has led to a negative impact on how they perceived not only in the general population, but also professionals in the medical field. They tend to be quite polarizing. And, I don't think there's any doubt that has led to them being inappropriately prescribed to many individuals. But I think that it's important to realize that there are a lot of people who would greatly benefit from these medications, and when prescribed in the right setting, that they can help a lot of patients who really need these medications, to improve their life and improve their health and their general functioning. So, I think it's important to, kind of step away from all of the media portrayal from that, and really look at these as promising treatments that can help reduce obesity and a lot of the chronic diseases that are associated with it. And From there, I'm going to go on to talk a little bit more about obesity. It is a disease. It's been recognized as such by the World Health Organization and the American Medical Association. It's a disease that's associated with increased inflammation, and that has led to many comorbidities. There's over 200 comorbidities that are associated with obesity. Some more common ones we hear about are type 2 diabetes, cardiovascular disease, cancers, especially breast cancer, colon cancer, endometrial cancer, osteoarthritis, obstructive sleep apnea, non-alcoholic fatty liver disease. The list goes on and on. So it's not only really about treating the obesity, but also a lot of these comorbidities that go along with obesity. Obesity is defined by your BMI. So that's calculated with your total body weight in kilograms over your height in meters squared. So a normal healthy BMI is considered 18.5 to 24.9. Overweight is considered 25 to 29.9. Sorry, I think there we go. And obesity BMI is considered 30 and above. That is further divided into class 1 obesity, which is 30 to 34. Class 2, 35 to 39, and class 3, which is 40 and above. And it's really the class 2 and class 3 that you're really starting to increase the chronic diseases, the morbidity and mortality associated with obesity. Now, kind of looking at rates of obesity in the US, I'm going to kind of scroll through these, and you can see as I scroll through the years starting in 2011, the green and yellow is decreasing, and the orange and red are increasing over time to this latest one in 2022, which shows a whole lot of red and a whole lot of orange. I think Washington, D.C. is the only green area left. And that's scary. Those are scary numbers. 1 in 3 adults now are overweight. 2 in 5 adults have obesity, and 1 in 11 have severe obesity. And so that's kind of that class 2 and 3 obesity. Again, that has increased in morbidity and severe chronic diseases associated with it. So really what's causing this? There's a sustained energy imbalance. So, I'll go into that in a little more in the next slide, but also genetics plays a role, environmental factors are playing a role, socioeconomic factors, medication, and other disease processes are all, contributing to these higher rates of obesity. And I think there's the 3 main things that are driving it. Our food quality has decreased. We're cooking less at home. We're eating out more. There's more restaurants and fast food meals. There's increase in the highly processed convenience foods, which are a huge problem in our food supply. Our portions have increased. If you look at this, I think it's incredible from the sizes of these, the beer, the chocolate, the French fries, the burger, the Coke, how much the sizes have increased since from when they were first introduced to 2002. So now 22 years later, I would imagine there's bigger sizes of all these things available now. Our activity has decreased. We've gone from very physical labor intensive jobs to sitting in front of a desk and sedentary jobs, and probably even gotten worse since COVID, because now you don't even have to leave the office. We can just sit at home and work from there and look at our desks, our screens. And even when we're not at work, there's been an increase in passive entertainment, video games, cable TV streaming services, internet. So when we're not at work on our screens, we're at home on screens. Transportation's played a role. You don't have to walk down, to get food anymore. You get in your car, public transportation, just general, conveniences that have also decreased how much we move, how many calories we're burning in a day. And kind of all of these things has led to this energy imbalance. Okay. And now some about the economic cost of obesity. So, you know, why this is important to have a good treatment for this disease. For each unit of BMI over 30, there is an additional cost of $253 per person. Obesity leads to excess annual medical costs of $1,861, with severe obesity being at $3,097 per adult. And the total cost of chronic diseases due to a patient having overweight or obesity is estimated to be $1.72 trillion, which, you know, it's equivalent to 9.3% of the US GDP. And I think, you know, these numbers again are speaking to the fact and emphasizing the fact that we do need a treatment for this disease of obesity. And again, this is a disease, it's a chronic disease that does require treatment, and it should be thought of as such. And so I appreciate everyone listening, and I'm going to turn it over to Dan.
Thank you much. Katie, if you can go ahead. I think we had another chart after that. We can skip to the couple slides there. I got it. There we go. So I think, you know, just kind of transition a little bit here. I want to talk a little bit about how, you know, Ochsner approached these in a couple of unique, I'd say, you know, had a bit of a unique challenge in looking at these treatments and these drugs. We are obviously a large health system, and because of all things that Dr. Dutcher just went through, we feel that there is immense value in offering these medications, and not only to our immediate, you know, challenges, hypertension, diabetes, and obviously obesity, which is, as we said, a disease that, as Dr. Dutcher said, but from a population health standpoint, our clinicians are firm believers that these drugs have a tremendous downstream potential, meaning that obviously for all those things that we just talked around, the eventual effects of obesity, if you can kind of bend that curve, just like we all try to bend the cost curve, we're going to see much better clinical outcomes. With better clinical outcomes, we're going to see better financial outcomes. But like many of you on the call right now, we struggle with the same challenge of being an employee health plan as well. You know, we have about 38,000 employees. We did cover these drugs because, again, we thought it was the right thing to do. And like many of you have seen, both from a health plan perspective, saw enormous costs that came along with that, as well as some of the, you know, kind of obvious, I don't want to say abuse, but misdiagnosis or misprescribing of these medications as well. So we really kind of had that challenge of, you know, how do we continue to cover these drugs? Because again, we believe there's benefit to them, while at the same time putting those guardrails in place to make sure that it's being prescribed appropriately, and to try to rein in some of those costs as well. So our own health plan approached our connected health division, which is where digital medicine and I sit under. It's really where a lot of our innovation as a health system, you know, derives from, and said, you know, can we come up with a solution to help us to again put those guardrails in place? They looked at a couple different options, probably some, you know, that many of you are looking at as well. Do we put in a prior auth or a pre-auth with the PBM? In looking at that, we saw some struggles there, not only the obvious negative member experience, but because many of prior authorizations look at different clinical factors or data-based factors. In this particular world, capturing things like BMI is difficult in claims data to capture. So administering that was tough, other than really just doing a clinical review with the clinicians, which is obviously going to say, you know, yes, I want my patient to be on this drug. So we want to look at different ways we could possibly put some of those guardrails in place, and how do we, you know, contain some of those costs. By actual coincidence, as many of you know, we offer under our digital medicine program, which started with our own patients and our own employee population, a hypertension and diabetes program that helps people to manage those conditions digitally, and now do that all over the country. We were in the process, as much as a little over a year ago, of designing a pre-diabetes / weight management program. So it's kind of a little bit serendipitous that this challenge hit our employee health plan around the same time we were developing some of these weight management components. And I think one thing, if you look through all those different step processes that Dr. Dartrieve went through, it was very clear that these drugs work the best when they are put in place alongside of a weight management program, something that also impacts that behavior change and doesn't just rely on the drug. And that's the reason why the actual clinical guidelines for these drugs requires patients and requires members to be in a weight management program, although again, very difficult to, quote unquote, police from a plan standpoint. So we started to look at this challenge as how can we put these two things together? And where we landed was to actually use the weight management program as that guardrail or as that gatekeeper, for lack of a better term. So we've actually devised a program for our own employees where members, in order to get access to this drug, which we are absolutely covering for both diabetes and for weight management, but in order to get a prescription for the weight management, it must be done through our weight management program. And because we have that advantage of clinicians that have that prescription of authority, which we use for hypertension drugs and for diabetes drugs, we already had that capability in place. So the process is we do get members actually enrolled into this program. We start right out of the gate with helping them with a dietitian and helping with the behavioral side, and a combination of both in-person coaching and digital coaching around the diet, exercise, weight, all those things that are required. But then also we connect every member with that licensed clinician, and that clinician is going to review the guidelines that are required. And you'll see this mirrors as an academic health system. We want our guidelines in a plan to mirror exactly what we saw clinically and what Dr. Dartrieve took you through. So in order to be in the weight loss program in general, it's when you get into that BMI that is above that typical what was considered healthy, so above 25. However, in order to be to qualify for these medications, that's when we start seeing that BMI above 30, or again 27 if there's some comorbidities in there. Again, 100% following those clinical criteria that are put there to get access to the drug. We then set up a virtual visit. We look at those different exclusionary criteria, just like Dr. Dartrieve went through, who is this a bad fit for, and then ultimately get them enrolled into that program and then write that script for them. So the advantage to this was actually pretty straightforward. One, we were able to ensure that every member is actually enrolled in a weight management program, which is kind of that first checkbox to get access to these drugs. Two, we then do a clinical review to say, is this appropriate for them? If it is appropriate, then we'll write that script and make sure that that no scripts are being written if it's not clinically appropriate. The most important thing from a plan design standpoint, however, was to work with our PBM to set up our plan so that only the prescriptions that are written through the weight management program are those which would be considered covered. So the advantage to us as clinicians is we're making sure that we're giving this only those people that are clinically eligible for it. The advantage to us as a plan and as an employer is the advantage that we are cutting down on and eliminating those off-label or those inappropriate prescriptions that are written, or frankly, if they are written, they're not covered by the plan. So we were able to make sure as a clinician and as a clinical entity, we're giving people access to these drugs, which we think are valuable, while at the same time, as being an employer and a health plan, putting those guardrails in place, that gatekeeper, if you will, to make sure that it's only those that are really clinically eligible and really should be getting this drug are getting access to it. So it gave us, as I said, that kind of unique advantage of we were building a program kind of anyway. This opportunity came up, we could incorporate that into that. So we ultimately ended up building a program that is obviously backed by a bariatric center of excellence. This was actually built with our entire bariatric unit, but led largely by Dr. Dartrieve, which hopefully you'll all agree is fairly knowledgeable and an expert in the program. But it is a fully clinical program, obviously backed by an 80-year-old academic health system. It's not just a mechanism to write the drug. It is a full weight management program. It includes all those the initial assessments, work with the dietitian, the nutritional counseling, both digital and in person. But then again, that last piece being, where appropriate, we can use these drugs to drive the outcomes that we're looking for. And then, like I said, we're able to report back to our own health plan or our external clients the ability of not only who's enrolled in this program, engagement metrics, et cetera, but what are we seeing from a success standpoint? Are we seeing that reduction in weight, those percentages? Is the drug working? Give that back to not only our plan, but our clinicians to say, do things need to be tweaked or managed as well? So really, for both our own employees and as an added benefit to our national program, which we now can offer in all 50 states and DC, even though they're the last one that's green, is we're really in a scenario where this program is looking at the entire cardiometabolic disease spectrum. And really when you consider that in any population that you're dealing with, almost anyone, whether it be a carrier plan, an employee plan, even some associations that we work with, there is a spectrum of people. There's a population that fit into this spectrum that goes from, and you'll see it here, from overall healthy, but really to that simply overweight, all the way through to, that severe risk or severe cases of cardiometabolic health, where we can now engage anyone in that spectrum, again, from just simply overweight to obviously multiple chronic conditions. And because of the clinical depth that we have and, the mechanisms that we've put in place, we can bring the correct resource and the correct clinical resource to that person based on where they individually are. So simple examples, if it's someone who's overweight, simply wants to lose a few pounds, coaching, behavioral change, work with a dietitian. Someone who is overweight also has one of these other conditions, high cholesterol, hypertension, diabetes, works with that dietitian, works with a health coach, also going to bring in a licensed clinician to talk about how do we best manage those medications. That now includes weight management, obviously, which is for obesity, someone who is overweight and meets those criteria for those medications. So no matter where that person fits in that world, we have the ability to engage with them, help them with the behavior change, and do the most important thing. And unfortunately, when it comes to manage these conditions, you can't do anything within a silo. It is that combination of behavior change coaching, but also making sure that they're taking advantage of these correct medications, make sure they're using them properly, they're taking them to drive really the true clinical outcomes that we're looking for, whether that be, the GLP-1s to lose weight, or these drugs to help them manage their diabetes or manage their hypertension or manage their cholesterol as well. So this is where we're at right now. It's been kind of a very fortunate timing as far as where this challenge met us as an employer, while as a provider of care, we're also developing some of these programs, but we're looking to expand this as well. From here, we're looking at things like chronic kidney disease. Can we take this spectrum out a little bit further, and how can we impact these people digitally as well? So at the end of the day, what we've developed is a very good solution, to some of the needs that we're seeing as an employer, and then what we're also seeing in many of the employers and the plans that we work with, but while also staying true to ourselves as a academic medical center and clinicians to make sure that we're giving the right care to the right people as much as we possibly can. So with that, I think we'll wrap things up. I think we have about 15 minutes or so left. I'd like to open up. Katie, do we have any questions in the Q&A or in the chat?
Thanks, Dan. Thanks, Dr. Daughtry. Yes, we do have some questions. All right. So question for Dr. Daughtry. If these drugs have been around since 2005, why are they now getting such attention?
I think probably bringing it back to the social media and I think it was really probably Ozempic that when that one came out and, became clear the weight loss that was associated with it. Well, you see some weight loss with some of the older medications. It wasn't to the degree that you saw that 15%, that you saw with semaglutide or Ozempic. And I think, really in large part, it's kind of been driven by the media attention around it. I hear all the time, I saw on Facebook, this person lost 30 pounds and now I want this medication. And so I think that's kind of been the large driver of it.
Thanks, Dr. Daughtry. Another question. Do you have engagement criteria that has to be met by the patient in order for them to continue to have access to the medications and to get refills on those GLP-1s? Dan, do you want to take that one?
You're muted.
I'm talking to myself. I think it's a better clinical question. So yes, we absolutely have those criteria. So there's the initial engagement, getting people into the program, an initial virtual visit to make sure that it's clinically appropriate, that they be on this drug. But then, and this is something people don't think about, frankly, and I learned this from Dr. Daughtry, that's why I'm going to turn it over to her, is there are specific criteria about continuing on the drug, and there's also dose titration, so adjustments in dose. And I think most people from a plan design, we think of getting people on the drug and continuing with the drug, but it actually changes. So that the true clinical management of this drug is really important, not just the fact that it's covered. And Dr. Daughtry, can you speak a little bit about initial results and then what you do if it XYZ?
Right. So when you originally start the medication, you start on a low dose. I'm going to speak specifically about Wegovy of 0.25 milligrams. And then after you do that for 4 weeks, you do that dose once a week for 4 weeks, and then you'll increase 2.5 milligrams. You'll stay on that dose for 4 weeks, and then you'll increase to 1 milligram. In the study designs from there, the patients would increase to 1.7 after 4 weeks, and then to the final maintenance dose up to 2.4 milligrams after 4 weeks. Clinically, I usually don't do the increase as quickly. I'll usually get a patient to the 1 milligram and then kind of slow things down a little bit, depending on how their weight loss is going, if they're having any side effects. And I do that simply because, as at some point, the weight loss is going to plateau. And so it's kind of nice to have that 1.7 milligram and that 2.4 milligram to go to when that does happen. And so, in clinic, when I see people, I see people usually every 2 to 3 months to kind of go over their weight loss, to see how they're doing, go over possible side effects. And from an insurance standpoint, there are, I have had patients who, it doesn't happen too often, but who are not losing weight, and the insurance companies will stop coverage for it. And it's generally, you want to see about 5% weight loss to continue the medications is usually the criteria used.
Thanks, Dr. Daughtry. We are getting some questions about, long-term commitment and what happens to patients when they stop taking these meds. This question here says, will this type of program prevent the word I'm hearing that these medications are a lifetime commitment and that patients put on the weight as soon as they stop?
So they do not put on the weight as soon as they stop. These are long-term medications. Obesity is a chronic disease. So, I kind of liken it to if you had high blood pressure and you went to your primary care physician and you were put on medications for hypertension to lower your blood pressure. Presumably your blood pressure would go down, but that doesn't mean you're cured of hypertension. That doesn't mean you stop the medication, because it's because of the actions of that medication in your body that's reducing your blood pressure. And so similarly, when you take these medications, they're working in your stomach to help you eat smaller portions. They're working in your brain to help control your appetite and cravings. And so while you are making these lifestyle changes, you're, eating less, eating smaller portions, hopefully eating healthier foods. When you stop the medication, you lose those effects on your stomach and your brain. And so over time, most people do start to regain weight as their appetite starts to increase again, as they're able to eat larger portions. So it is a long-term commitment. How I handle that with patients, it kind of varies. So some patients they want to stay on the medication every week. They like the control that they feel over their eating habits. Some patients will reduce their dose at some point. So maybe they don't need the 2.4 milligram dose anymore. Maybe they can go down to a 1 milligram dose, and that would control their appetite sufficiently. So, how that's handled on a patient-to-patient basis kind of differs. But again, yes, this is a chronic disease that does, require long-term management.
Thanks, Dr. Daughtry. Getting some questions around some specifics around the program. So question around, does an employer have to offer GLP-1s to have access to the program? And then also, can members in a different state participate in the program if they're not being seen by an Ochsner doctor?
So I'll take those. No, absolutely not. First of all, they don't have to offer the GLP-1s. As I said, we were working on a weight management program / prediabetes as a to round out our suite of services that we offer for hypertension, diabetes, and high cholesterol. So weight management is still a huge component of combating obesity with or without the drugs. So the coaching, the access to a dietitian, the both digital and in-person counseling, absolutely are part of the program, whether you're covering the GLP-1s or not. And again, we started this just like we started everything else. We start with our own employees and our own patients because that's from a clinical perspective the way that we vet every program that we do. But this is actually a program that's available in all 50 states with licensed clinicians in all 50 states. So no, it does not have to be tied to an Ochsner clinician in any way, shape, or form. It's offered as part of like any other benefit, and it's available in all 50 states. And that is, again, I think this is just to go back to the last question, just like any other chronic condition, the goal, no one likes to take medication for the rest of their lives. And I think that just from a sheer cost perspective, because even in most plan designs, even if the coverage is there from the employer, there's usually pretty substantial member cost share. I know there is from our perspective. So, there's varying degrees of varying opinions as far as how long people should be on these drugs. Are they a jump start? Are they a chronic condition? So, from a clinical perspective, as long as it's appropriate to someone, we'll keep them on, just like Dr. Daughtry said. But we do get feedback from members that say, look, I can't keep paying for this, or I don't want to keep paying for this for long term. And I know our plans don't necessarily want to keep paying it long term either. So that's why it was so important to put it with a behavioral change program. To Dr. Daughtry's point, as they're eating less and as they're taking smaller portions, the behavioral piece to get people used to that and train themselves that that's what that's normal to them, so that if they can come off the drug without that appetite coming back up or without moving back up, that's obviously the goal of combining the two things together.
Thanks, Dan. That's a great segue. We are seeing some questions around, using that combination of the drug therapy and behavior change, and some questions around, are we able to see a real medical ROI? And, is there any studies that are showing the impact of what healthcare costs could look like 1 to 3 years down the road?
Well, we've already seen, and Dr. Daughtry showed some of the longer term through those different steps that we went through in from some of the studies that were done, and those went into long-term outcomes. I think that we know that while it's always tough to tie specific dollar amounts, we know the cost of obesity, right? We know that obesity is ridiculously expensive. So if you can move that needle by 1% across any population, there's obvious savings there. If you can keep people from moving, and actually I accidentally left this slide up, but if you can keep people from moving through these different parts of the spectrum, there's obvious dollars tied to that, in the fact that, and you can do the math if you'd like. Any health plan can look at the average cost of someone who's overweight versus the average cost of someone with hyperlipidemia, with hypertension, and do kind of the math and the opportunity cost of keeping people from moving from one to the other, because those numbers go up as you move up, through this spectrum as well. So there's the overall opportunity cost of keeping people out of a condition. There is also, and I know people put less emphasis on this, but there's obvious productivity conversations to look at as well. Presentation went away. There's obviously population health and productivity costs. As a matter of fact, many of you might have seen there's an article that's put out by Goldman recently that estimates that the overall GDP might be in the United States might be impacted by over 1%, which is a lot of money. simply by the fact that people are overall healthier the more they use these drugs. Now, that's a lot of supposition, but I think we're going to see more. These are all fairly new. I mean, as Dr. Daughtry said, most of these have just been approved in the last couple of years, especially for weight loss. So the numbers will bear out, but I don't think there's any question that we know if you keep someone who's obese from continuing down this spectrum, they're saving any population there.
Right. And I mean, I don't know exact numbers, but, I see patients getting off their medications for hypertension, reducing the number of medicines you need for obesity, for diabetes, avoiding that knee replacement surgery, so I think the cost savings from all those things, will need to be taken into account too along the lines.
Great. Thank you. Another question came in, for plan sponsors concerned about costs of these meds, what new meds will be coming and any innovations coming beyond GLP-1?
Well, I mean, the newest one that came out, tirzepatide, that one is both a GLP-1 and a GIP agonist. So GIP is another gut hormone that controls appetite and hunger, among other things. So, that one actually does, that one usually results in about 20% weight loss. They're looking at oral medications for people who aren't so keen on injecting themselves. So there's some other things in the pipeline for this medication, and GLP-1 agonists in general. There are a lot of studies looking at, its use in addiction and liver disease, and I think Alzheimer's, and also.
Katie, I'm seeing a couple questions around the PBM, and I want to make sure we answer these.
I was getting ready to, that was my next one. Yep.
So a couple questions around the integration with the PBM. It was actually fairly simple. Again, setting up a prior auth was a little convoluted. We have the advantage that our clinicians are only a part of this program. They're not the clinicians that are managing the medication. So it was actually as simple. We could do this with any PBM. We gave them a list of the NPIs, so the provider indicator identifiers for the clinicians that would be writing these drugs. And that PBM simply put a filter in place that said it was only covered, it was written through those NPIs. So that was fairly simple. I have heard, there's another question here about rebates, et cetera. We did hear, and we got some feedback from some other employers that said that not necessarily the PBM, but the manufacturer might try to pull back some of the rebates. We ended up, that question did come up, but it ended up going away fairly quickly. Like anything else, I think the larger the employer, the more leverage that they have. The argument when really you got into it, started to push back on the manufacturer or the PBM, that we were limiting, the argument that they made, which I'm sure is where you're going, was we were limiting access to the drugs, so hence the rebates should not apply. This program's not limiting access to the drugs. As a matter of fact, a prior auth might. But this is not limiting access to the drug. We're just ensuring that only those that are actually clinically eligible get it. And it was difficult for the manufacturer to make the argument that they want people that are not clinically eligible to get it. So the argument kind of broke down pretty quickly. But we have heard some noise around that, but it's pretty easy to dispel. One of the employers that we worked with, it's I don't know if I want to release, I won't release the name, but actually even made the case that even if it did go away, they're about a 32,000 life employer. The $200 or $300 or so, even if they reduce the unnecessary or the inappropriate writing of these scripts by 10%, would cover the rebate, even if they did lose it. But that became a moot point because we didn't lose the rebates.
Thanks, Dan. I think we've got time for one more question. See a question here. Have you integrated risk adjustment, STARS, VBP data acquisition into your obesity program? And what would that best practice look like?
We're still working on how do we, I mean, integrated, we'd have to see what you mean by that. A lot of the clinical outcomes that we report on, similar to hypertension and diabetes, are the exact same things you're going to need to impact STARS ratings or HEDIS measures, et cetera. So when we look at things like the simple things, are they taking their medications, the medication adherence? If we look at overall reduction in BMI or reduction in A1C or reduction in blood pressure, those are, or the very fact that people have checked their blood pressure in some cases, those are those metrics that usually need to be captured to impact things like stars ratings and HEDIS measures and things like that. So a lot of our standard reporting covers much of that anyway. But in our carrier relationships, we've typically looked at, where can we, build a data extract where we can pull that information so that the carrier can pull in what they need to, check boxes across their different HEDIS measures or stars ratings.
Excellent. Thanks, Dan. Well, I know we are at time. Do we want to be respectful of everyone's time this morning, so we can end there? Or I think we've got through most of all of the questions at this point.
We'll go through, and if there's any that that we didn't get, we'll in the follow-up when we send out the recording, we can certainly send out some information around that as well.
Absolutely. Absolutely. Excellent. Well, Dan, thank you. Dr. Gottfried, thank you for your time today. Thank you for everyone that's that joined the webinar. Been great spending the morning with you. And yes, as Dan mentioned, we will send out some follow-up information and a recording link for you to view this on demand at your own time if you'd like to dive into it again. So thanks, everyone.
Thank you, folks.
Thank you.